Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is anterior segment challenges with Dr. Marc Bloomenstein. He is Director of Optometric Services at the Schwartz Laser Eye Center in Scottsdale, Arizona, and President of MRB Eye Consultants. He is the Chairman of the Education Committee for Vision Expo. He has served as the Chairman of the AOA Continuing Education Committee and served on the board of the Ocular Surface Society of Optometry, as well as a founding member of the Optometric Cornea, Cataract, and Refractive Society. Dr. Bloomenstein has served as the president of the Arizona Optometric Association, legislation chair, and president of the board of the Arizona Optometric Charitable Foundation. He has delivered over 1,500 invited lectures worldwide, served as a principal clinical investigator in over 25 clinical trials, and consults with numerous industry-leading pharmaceutical, biomedical, and information technology companies. It's really our great privilege to have him come and share his expertise with us. So, Marc, please take it away.
Thank you, Joe. Thank you, Greg. Thanks for having me. Welcome everybody to your Tuesday night edition. I'm just going to get into it. I'm not one of those clinicians where you just find just random things that just happen and you decide you want to write a case about it. Hopefully these are practical and things that are relevant in your practice as well. As I just messed this up. Did I screw this all up already? Hold on. Yes, I did. There we go. So this is me. Here's my financial disclosures. If you guys could tell me what all financial relationships mitigated means, I'd appreciate it. I have no idea. But hey, let's just go with it. So here's our first case. Okay. This is the case of a lowly patient who developed floaters and decided that he was going to go and get a picture taken by the center view IDON. So the IDON was sitting in the Vision Expo in New York. It was in the hall. If you can't figure out who this patient is, it's me. It's me. It's me. Now, a lot of you guys are probably looking at this saying, oh my God, dude's got glaucoma. I see there looks like there might be kind of a little bit of a calcific kind of a little occlusion there. You might also notice my macula is a little dark, all kinds of other good stuff going on. But you also might notice that there is a horseshoe tear right over there. Now, I bring this up as a cautionary tale. I like to always kind of talk about the fact that it's, I think sometimes we as clinicians take things not lightly, but we just kind of think, it's almost like the wolf or the sheep that cried wolf, from the perspective that we're constantly seeing patients hearing about floaters and flashes and how big of a deal is it. And I was that person. More importantly, my floaters started developing. I just had this big floater and I would sometimes see a flash. It would kind of come, it kind of go, but it never really affected me. And so I just never really thought it was important to get an exam. The truth of the matter is that I never did get an exam. I never did have a dilated exam. I was prodded by one of our colleagues to go into the exhibit hall. And this was one of those holy crap moments when they did this. Another reason why I like to show this case is because for anybody who questions whether or not doing a non-mydriatic camera, full field camera is worth it, my pupil size was 1.4 millimeters. This was a 1.4 millimeter picture of my peripheral. This is my left eye. You can see there it's kind of a superior kind of horseshoe tear there. I was blown away. The funny thing is I came back from Expo. A couple of people are telling me, "Oh, you got to go to Columbia," and I go, "What? Bogota, Medellin? Where should I go?" They're like, "No, go to Columbia University." And I'm like, "Why?" I go, "It's okay. I've probably had this for a while." But when I came back on Monday, I called the guy that I refer all of my patients to, and he didn't answer. It went straight to voicemail. So around noon, the surgeon I work with said, Marc, haven't you gone in to see somebody about your eye? And he goes, call him. And his name is Dr. Dinesh. This is a guy that's like been coming into the practice trying to get me to refer patients to him. So I call him and he goes, oh, Dr. Bloomenstein, I want to set up a lunch with you. I'd love to meet you. And I go, well, I kind of have a situation. And he said, well, send me the picture. He pulled over in his car, calls me back, and he says, dilate your eye and meet me in the office. Now, I don't know if you guys, Joe or Greg or anybody listening here, has ever had laser done. Have you guys ever had laser done?
I've only
Peripheral.
had LASIK done. I know I have not had an argon done to
Okay.
my eyes. So that's in a good position now, right?
It's
That's a good place to have it.
yeah.
Just a yag.
Yeah, no, they suck. So whatever you think by telling your patients, oh, it's just this thing hurts like a mofo. I shart every single time he shot me with it. I'm like gripping the handles and I'm like panting. I'm out of breath and I go, we're almost done. And he's like, yeah, we're almost done, like 50 more shots. And I'm like, are you effing kidding me? Oh my God. So I had to go back because I had two more holes in the other eye. And yeah, I've never been back. But I went back in a year later. Here I am a year later, going in back into go see eye care. They took a picture of my eye again with the iodine, and you can see the beautiful laser treatment that you do around that hole to kind of tamponade it. You can see the other periphery where they did some more treatment too. So I throw this case up here partially because it's hubris, partially because, it humbles me. I see patients all the time that come in and say, I've got a floater, and I'm like, meh, are you having flashes? Meh. But it's really important to make sure that you look at the peripheral retina. I mean, less than 5% of tears, or let me see, it's 5% of tears happen within the immediate PVD. So you have less than a 95% chance of it happening afterwards. But the truth of the matter is you're not going to know unless you dilate them and look at them. So, there's me. There's our first case. Our next case I want to talk about is just kind of another eye-opening for me. This was Bobby. This is Bobby. Bobby. His last name starts with a D. Bobby's a fireman here in Arizona, but more importantly, he's a fire captain. He is the father of my kids' friends. So you guys all have those family friends where it's like, oh, they know your kids, they know you're an optometrist, so they're like, hey, like, do you take new patients, or do you sell Ray-Bans, or can I get some Oakleys over at your place? So I've known Bobby. Let me see. My daughter is 27. So I've known Bobby for almost 23 years, 25 years. And so I would see Bobby, and part of the reason why I showed you the pictures on the right-hand side is that in the upper right-hand corner this is Piestewa Peak. Piestewa Peak is otherwise known as Squaw Peak. So if you come to the valley, if you guys come for the AOA, you absolutely have to hike this. It's right down, it's literally almost downtown Phoenix. It's about a 3/4 of a mile hike. It's about a 40% grade. It's a trek, but it's a beautiful hike. You can see people sitting up there. But if you look at the lower right-hand corner there, do you see the person in the being helicoptered out on that bed? Well, about, I don't know, 5 or 6 years ago, there was a woman who fell, and she was trying to be helicoptered out of there, and one of the cables on there broke. So I don't know if you guys saw the news report of this woman just with centrifugally just kind of spinning around underneath this helicopter. Yeah, so she sued the city for I don't know how much, but that was Bobby's unit. So Bobby was on the news, talking about this, so he has to be up in front of the camera. So he lets me know he's a big deal. So he calls me, and he's been getting these bumps. And I'm like, okay, Bobby, getting these bumps. But more importantly, the bigger issue is with the bumps is that he feels like they keep coming back. Now, I would meet him at the mall. I just kind of look at his eye, people like to call it a sty. I'm like, I'm not into styes, it's a hordeolum, get it right, Bobby. Okay. Start him on moist heat pack or a Z pack, all the things that we would do. And that would help him for a short period of time. But around 2023, he tells me that he feels like they're just kind of coming fast and furious. And because he's in front of the camera, it's becoming an issue. Okay. So you can't really see it all that great in his eye. But if you look at his left eye there, you can kind of see at the very lower lid there, it's starting to come back again.
And if you use your pointer, Mark, they can see that. Just
Okay.
FYI. So
Oh, yeah,
there you
right there.
go. Yep.
So right there. No big whoop, but for him, it's starting to develop. And Bobby's one of those guys where he's like kind of in tune with his body, right? It's like, I know I'm starting to get sick, or I know I'm starting, so he knows he's starting to get one of these. But the truth of the matter is that I was looking at him and I was thinking there's something else going on. And I have never been somebody who subscribed to Demodex. You hear about all these guys talking about Demodex and, Kathy Mastrada and Ben Gaddy, or just, eat, drink, and breathe Demodex and pulling lashes. And I never really subscribed to the notion that they were very symptomatic, and I couldn't really correlate what they were doing. But the bigger thing was that we never really had good treatment for them. But the one thing that I noticed on Bobby is that, he was starting to develop, more of these lesions in and around his eye. But the other thing too is that Bobby had a tremendous amount of collarettes. And that was one thing that I significantly noted on his lids. Now, we'll talk a little bit about collarettes, but this is, you have those N of ones. Greg talked about the, waste management. I'm not a golfer. There's golfing, I could go golf every single day. There's a different golf course here, but everybody always talks about that one great swing, and then you're going to golf for the rest of your life. To me, I kind of feel like you find one patient and you get a good treatment, and it changes the course of this patient and really makes you think twice. So 2023, you may or may not remember, is when a small company called Tarsus was in their clinical trials for lotilaner. And I was reading a lot and hearing a lot about this. And I said to Bobby, I said, I think there's a correlation there. And I think that the correlation between the fact that you're getting more Demodex and the fact that you're starting to get more hordeolum, and I think, there's been some studies in China demonstrating that young school kids, about 60% of the kids that had chalazions or hordeolums actually had Demodex, and then in their control group, none of them did. So I feel like there's something there. And so I said, Bobby, when this drug gets approved, you're going to be my first patient that I prescribe. Okay. So talk to him about this. He's like, do you think it's what's causing my lid issues? And I'm like, you know what, homie, I don't know. We'll try. So he was my absolute first patient that I prescribed it for. He was my 7th patient that I actually was able to get it for. So if anybody remembers how hard it was to get this drug, but he said to me things that were just incredible. My eyes feel amazing. He goes, this is great. I think he said something along the lines of, you're probably the best doctor in the entire world. He may have said that, I don't know, something to that effect. But August of 2024 rolls around. And coincidentally enough, it's kind of rolling in. This is me getting my, pictures taken at Vision Expo again. And he calls me up and he says, I think I'm getting a bump again. He goes, I started my XDEMVY from last year. And I said to him, I go, okay, that's cool. He goes, can I get a refill? And I said, yeah, you can. And he goes, good. 2 days later, he calls me back. He goes, the bump never developed. And he's like, this is amazing. So I started like looking into this a little bit, and, these are images of Laura Perriman. You can kind of see her treatment strategies. Laura is in the Pacific Northwest. She's loves to kind of, she's a little dry eye master, if you will. And Laura is always kind of tinkering around looking for different things to treat. And one of the things that she noted also is that there was an increase in Demodex and hordeolums. And you can kind of see, the improvements in the appearance after one session of IPL treatment with a patient. And I think IPL is great for patients that have a lot of inflammation, patients that have, concomitant meibomian gland dysfunction, or, the telangiectasias. But it doesn't work necessarily as great on the Demodex because it only works on the exoskeleton. And so I think the combination of maybe doing like, a microblepharoexfoliation with lotilaner combined with intense pulse light is going to be your best option. If you're not doing IPL, then you absolutely need to do use lotilaner. But if you're only using lotilaner, then you don't necessarily need to do IPL. That's my personal opinion. I'll leave that out there. Something else that Laura commented on, and I've really subscribed to it, is that, when you have a hordeola, you may not necessarily always see the collarettes. And remember, collarettes are basically, they're debris, they're carcass, they're feces. I love to tell patients they're just, these mites don't have a excretory system. It's believed they don't have an anus, so they just leave it all out there. It's kind of like, like a party over at Greg's house. It's like, this is what it looks like, after the party. It's just everything's out there. You got to clean all this up. And who's going to do that? Nobody. So what lotilaner does is it comes in and kills the mites and gets rid of it. But you may have an overproduction of these mites even without seeing a lot of the collarettes, because I'm going to show you in a second here, they reside not only just in the follicles, but they also reside in the sebaceous glands, because there's two different types. And if you look at the lower left-hand side picture here, this is what Laura calls the alpenglow sign. Now, an alpenglow basically is that if you look at a mountain range right around dusk or sunset, you can see the trees kind of hanging out there in the glow, and that's called the alpenglow. It's beautiful. So if you see these little, there's almost kind of just like cilia that are popping out in the, between the bridge of the nose. Laura went in and she kind of pulled those, and she was able to demonstrate that you can see Demodex within those follicles, within those sebaceous glands. Now, does that necessarily kind of like, imply 100% that you're dealing with, patients that have Demodex? Well, not necessarily, but what it also does do is it gives you kind of a stronger belief that the rosacea, the Demodex, the increase in the bacterial load that these patients have. Because remember, Demodex carries with them different forms of bacteria. There's bacteria on the outside, staph and strep, but on the inside, they have Bacillus olearum, which is not unique to us. So a lot more bacteria, which combines, and I'm always looking for what is the impetus for causing these patients problems. And at the very least, if we can go in and treat it, treating the Demodex in the office, you talk about with rosacea as another perfect example. If I see somebody with rosacea, I'm thinking hordeolums. If I see somebody with, rosacea, I'm thinking meibomian gland dysfunction. But I'm also thinking Demodex is maybe the key to both of those. You're going to see probably this year, there's going to be some clinical trials looking at management of ocular rosacea as a way of kind of thwarting some of the meibomian gland dysfunction and some of the dry eye problems we have, as well as the hordeolum. But you can really see improvement, especially, with kind of like off-label things like ivermectin cream, but using those in-office treatments that we have. So real quickly, lotilaner, if you're not using it, it's the only treatment. And, what's interesting is that, when you go through a course like this and you talk about Demodex, there's only one treatment. I mean, we've had other options. We've had IPL, we just mentioned ivermectin cream. We talked about, tea tree oil, buckthorn oil, but those don't eradicate the mite. What those do is they kind of, they slow down the progression, but they don't remove it. What these do is kill them. They get in there, they neutralize the mite, and they basically paralyze them. And in their clinical trials, they were able to demonstrate that, if you look at lashes of 150 lashes, you can see that collarette reduction to 50% compared to vehicle, less than 2. But look at the bottom one, 85% compared to 28% of the vehicle for less than 10. So, and the average person in the trial had like 100 collarettes. So you nasty. But this is all fine and dandy. That's great. We're getting rid of the collarettes, getting rid of the Demodex. I never take too much when I look at a clinical study where it talks about erythema or redness, because patients come in and say things like, my is so red. And I'm like, yeah, that's so, which eye? Which eye is red? I mean, to me, that redness, itching, and all those things are in the eyes of the beholder. And so when I start thinking about Demodex and meibomian gland dysfunction, and I think about eradicating these mites, I'm also thinking about where they're also residing. The brevis mites, as you can see in this cross section here, they're in the sebaceous glands. They're also in the follicles, the folliculum. Gosh, that keeps changing. That's so weird. So they're in the folliculum. You can see them also kind of creating some of that bacteria and things we just talked about. So there was a study that was done, and the study basically was looking at patients that had Demodex, okay, but also patients that had meibomian gland dysfunction. So what they did is they took patients. Now, if you go back and look at the original prevalence study, they showed that about 60% of patients who had Demodex blepharitis also have meibomian gland dysfunction. So what they did in this study is they said, let's look at meibomian gland yield secretion scores or expressible glands, see if they're reduced, tear breakup times reduced, but they also don't have issues with Schirmer scores. But the bigger thing is that they have Demodex, and they have to have Demodex to the same level that they did in the original study. And on the left-hand side, you see that it was by 55% treated to 0, 80% treated to less than 10. And that literally was exactly what they found in the clinical trial. The clinical trials were called the Saturn trials. So these were called Ursa and Rhea, okay, which obviously are planets that rotate around, or excuse me, moons that rotate around what specific planet? Yeah, it's Jupiter. It's Jupiter. Makes no sense to me why they did that. But if you see here on the right-hand side, when they pressed on the gland, so when you think about it, you're doing your meibomian gland, you're pushing real good. You're looking for some juicy disgustingness. You're vomiting in your mouth a little bit. You also notice they have Demodex. In this study, if they went from olive oil to baby spit up, or if they went from baby spit up to harder, kind of more kind of tube-like inspissated glands to 0, what you're looking here is seeing patients that got better. So 54% of the patients just treated only with lotilaner had an improvement in their yield of their glands, meaning that it improved from that crappy gland to maybe a little better than crappy. But I don't even care about that. This is what I care about. What I care about is hearing what patients think about it. So the one thing they did in this clinical study, which was really phenomenal to me, is that they said, let's ask patients before they have the treatment and then after they have the treatment. They did what's called the visual analog score. And if you're not like me, who's not smart, I always think visual analog. I think vision. I think, I don't know, logmar. I think, Snellen and acuity. What does it have to do with itching? But a visual acuity chart is essentially a line. And on one side, it says it itches like a mofo. And on the other side, it says, I don't even know what you're talking about. There's no such thing as itching. And it's 100 millimeters. And a patient basically puts an X on there. And then you measure it. And that's where you get that number from. So if you see fluctuating vision, there was a 59% improvement that patients' perception that their vision was better after using the XTP, using the lotilaner. 66% improvement in itching. But the redness score is the one that matters the most to me too, because that implies that patients are actually objectively noticing a difference. They can see something, okay? And whereas I'm very subjective about it, patients, when they don't have red eyes, they think their eyes feel better. So all of this combined, Bobby, the studies, the data has really kind of led me to kind of this belief that if we're managing these patients with chalazion or hordeolum, is really look for the lids. Look there, think about how you can manage that bacteria, the rosacea, and get these patients moving in the right direction. So we have our first polling question, Greg.
All right, let's get that launched.
So Dr. Bloomenstein had a horseshoe tear in his which eye and located where in the retina? Was it in his right eye inferior? Was it in his left eye inferior? Or is it right eye superior? Or was it his left eye superior?
Okay, polling question is open. Joe, do you have any questions?
Yeah, a couple of questions, and they're gonna be pretty straightforward. Dosing for lotilaner, I think we all know, is twice a day in each eye until the bottle's gone.
Or
Somebody asked it.
well,
What?
it's originally it's actually for 6-week course. But
Yeah,
I love what
42
you said.
days.
Yeah, but I love what you said, Joe, because if you're managing these patients with meibomian gland dysfunction, especially because I think everybody does, then you got to get it in there in a little higher concentration because the brevis is a little deeper. So I tell the same thing. I tell patients use it till the bottle runs out.
And we have two kind of questions we can merge together about being covered by medical insurance and the $2,000 cost. And yes, that is true. It is $2,000 plus, off the shelf, unless you work with the company. So, and especially pharmacies. So Mark, why don't you handle that?
The one beautiful thing about when new drugs come out is that the pharmacists do, or excuse me, the companies do everything they can to kind of lower the cost for patients. I will say that's why I said to you, Bobby was my 7th prescription filled because it was a challenge getting these. You absolutely have to do a prior authorization, but your staff, Tarsus, I think they'll definitely work with you as to what verbiage. The nice thing about this drug, though, is that you don't have to do a pass through. There's no other medications to say, I tried, I did this, I did that. You can make your life a little easier by saying patients use tears, patients use lid scrubs if they did when you send in your PA. But the vast majority of commercial insurance pay less than or around $30. For your Medicare patients, though, if they're covered, then what I want you to tell your patients, now here's the other thing too, is you really need to send them to just the pharmacies that have been contracted with Tarsus, and that's CVS Specialty or Community Walgreens, Blank RX, those places. What they will do is they'll tell them how much it's going to cost, and I want you to tell your Medicare patients to tell them that you can't afford it. And what they are going to do is offer them a grant. There is a $2,000 grant that is available for rare diseases, or better yet, for diseases that only have a single treatment. And I've had patients get this grant over and over again, and they basically give them the drug for free, and they mail it to them. So it's a
Mark,
worth.
let me just echo a couple things that you're saying there, just for the audience, because I think the audience, they send it in to their local pharmacy, it gets denied, and then they get frustrated. And I think for you, Joe and I, we're just so used, being key opinion leaders and working, and we kind of learn to kind of work around when every new drug comes out. So I'm just going to echo, just say the same thing you did. Work with your reps, track them down, ask them to talk to you. They'll help you out. Like, there's a specialty pharmacy, I don't know which one they were using, Blink, but my rep comes in and says, hey, I've been working with this Walgreens in Pittsburgh. They'll take care of it. So I send mine to the Walgreens. They work with them closely. They get that prior auth going. So work with your rep, work with your specialty pharmacy. I use the verbiage is that it's the only FDA approved drug that's for Demodex blepharitis that's out there. And it really is. You can put down some of the treatment failures that are out there, but this is really the only FDA that seems to get it working. So basically everything that Marc said, but just echoing, just do it. Be committed, reach out to your rep, because if you send it to the Walmart, you send it to whatever they want, the local pharmacy, you're going to get denied, and then you're going to get frustrated. And it is a great treatment. I will echo, this is a great treatment. It is life-changing for the patient, because when it works, man, it works. And that's all I got.
The last thing I'll say is, I mean, when I tell a patient, I think you guys do too. I don't ask them. I don't say, hey, is it okay? Hey, this is what I tell them. I say, you know what? I notice that you have, an excess amount of debris at the base of your lashes. We call it collarettes. You have an overproduction of these mites. I really feel that it's contributing to your hordeolum, your chalazion, whatever. So I'm going to prescribe you. I let them know this is what we're going to do, because I never can understand doctors, our colleagues, that a patient comes to see us because they want our clinical acumen. They want us to tell them what they need to do, as opposed to giving them, kind of an option platter. This is what's going to be in their best interest, and then working with them to make sure they get it. So, yeah.
All right, here's the answer to your question. So the 90%, 92% got the left eye, and then 72% got superior left eye, and 20% went with inferior left eye. So,
Okay, so people, you need to listen a little better, okay? Okay, so the title of this is O for F's sake. Yeah, it was left superior. Okay, I'm gonna leave it at that, right? Moving on, Greg.
boom.
Go.
Go ahead.
Moving on. Here's our next case. What the F? This is a 67-year-old white male. His vision's not good. It's been blurred. Cries a lot too. He cries all the time. Do you guys remember those videos of those little kind of cartoon things? I cry. My eyes cry all the time, and I have 20 pairs of glasses, and none of them work. Can you read my glasses? Am I the only person? Am I the only one old enough to remember those things?
I know what you're talking about. I'm old enough.
Yep. Non-insulin dependent, diabetic, controlled, no known medical allergies and a history of a skin lesion that he had removed from his cheek, which is my favorite skin lesion. We'll talk about that maybe at some point. Truth be told here, whenever I see non-insulin dependent diabetic, my thought is going to the cornea, looking for dry eye, looking for meibomian gland dysfunction again, because I think too quickly, all of us think, diabetic, we think diabetic retinopathy, but don't forget about the keratopathy, people. You know what? Apathy is apathy, lack of oxygen, not getting to the tissue that it needs to. These patients are going to have a lot more anterior segment issues as well. But we see here his vision was best corrected 2030, pinhole to 2020 in his right eye. His left eye was 2100, pinholing to 2070. There is a image of his left lens, 2 plus gutata on his cornea. It might have actually been, 3 plus with some pigment on the endothelium. That's always kind of a precursor to me for knowing that this is somebody who probably has Fuchs dystrophy. Now, you look at that cataract, and again, if I can give a PSA to my colleagues here, this is the type of patient that comes in and tells me the last doctor I saw says I have a baby cataract, or I have the beginnings of a cataract. To which point I just sigh a little bit and I just go, and I'm like, well, you know what? Having a cataract is like being pregnant. I go, you can't have a baby pregnancy. It's either you are or you're not. The question is, where are you in this process? Moreover, you are developing a cataract the minute you're born. And part of the reason why is because this is oxidated tissue. This is, proteins that are building up in the lens, and it's just something that happens every single day from the beginning, of life. So us as clinicians, instead of looking at patients saying, well, you have this starch at the beginning, no, you know what? When you get the cants, when you can't see street signs, when you can't do something, then that's the time to start thinking about cataract surgery. But it's still a cataract, even if they don't need to have surgery. The other thing too is if you look on the side over here, you can see this milky kind of just opacity. And the milky nuclear sclerotic cataract is one that evades a lot of clinicians. And the main reason why is because you can look right through it. It doesn't really distract from your ability to see the retina, but it does affect your patient. So my man had cataract surgery. Here's his vision. He used 2100. Now, if you've never seen some of this good stuff that you see on this picture here, like stria, 3 plus, post-operative microcystic edema, I'm assuming there's 1 plus cells in there. The eye was centered. Now, we use in our practice the ocular response analyzer. It is a device from Reichert, which measures hysteresis, and it takes hysteresis into account when it's kind of calculating out the best IOP. The main reason why is because, the Imberg-Fick law for intraocular pressure, which is what Goldman uses, it makes assumptions, and one of those assumptions is that the cornea is 520 microns. This is not a 520 micron cornea. So you're going to get false highs, false lows. You don't really get great pressure assessment. But using the ORA, which is a non-contact tonometer, it uses a little puff. It's a kind of a modulated puff. It was 14 millimeters. Now, just looking at this, I'm going to be honest with you. I've been working with cataracts procedures for 30 years. So none of this stuff really kind of, scares me. I don't, worry about this. But I do think that it's always kind of cool that you're prepared and you know what to expect. And if you've never seen cells in flare, if you've never seen a hyphema, if you've never seen microcystic edema or stria, then find a really crappy ophthalmologist in your town. Somebody that you would not refer to. Somebody that if they say, what do you think about him? You just go, no. And just say, hey, I'd love to follow you around for a day. That way you can kind of see some of this good stuff. That's what I'm gonna tell you. So this is my friend. This is what his eye looked like. Now, one of the things that I always worry about when I can't really see in the back of the eye, I want to make sure things are normal. I can see that the macula look normal, front of the eye look normal too. Now, we talk a little bit about Fuchs dystrophy. This is a autosomal dominant inheritance. This is bilateral for both patients, and it can be asymmetric. The interesting thing is that when you think about a dystrophy implies that it's something that you are born with. A degeneration is something that happens secondary to something. Okay, it could be systemic, it could be environmental, but when you think dystrophy, you think Lady Gaga, born this way. Okay, and so the interesting thing is that most dystrophies, if there's a genetic component, you're born this way, you would start to see them sooner. But here, especially like with Fuchs, this one starts about the 5th decade. It starts building up because what happens is you get this accumulation of these kind of secretions that build up on the endothelial tissue. They start to break it down. Okay, you start to see those are called little guttata, and then you basically get the separation of the endothelium. The endothelium dies. It tries to kind of stretch out and kind of fits its place, and then you start to see all these endothelial cell drop out. So most of these patients, a lot of them are women, 3 times more than men. But you're looking for those just little guttata. You're looking for that pigment epithelium. And this is what happens, when you do an endothelial cell count prior to surgery, you're looking at all these hexagonal looking cells. And these are all endothelial cells. And all this area here is tissue that's gone, that they're drop out. And as we all know, the endothelial tissue basically kind of acts as our little pump, which kind of keeps the cornea nice and clear. And the problem is that when you have a loss of those, then you start to get edema, you get swelling, and it just makes things a lot harder. Back in the day when I had patients who had mild Fuchs or mild, just kind of guttata, when they first wake up in the morning, their vision's worse because they're not getting as much oxygen. Your eyes are always a little more swollen because you're only getting about 80% of the oxygen that you normally would because of your lids. So when they wake up in the morning, sometimes I would tell patients take a hair dryer, maybe just stick your face out your car window as you're driving to work, just kind of desiccate that out because it gets a little better as time goes on. About 10% of patients with Fuchs develop recurrent corneal erosions. So one of the things that's really important, especially with these patients, is that you monitor them. This is a patient who's diabetic. This is a patient who already has edema. Now you have some swelling on the cornea from the Fuchs. It's kind of a volatile situation. These patients I like to prophylactically manage with maybe an immunomodulating drop, something like a cyclosporin or a lifitegrast, just to kind of temper some of the inflammation on the ocular surface. I watch them really closely to maybe start them on something like a loteprednol, but it's something to kind of keep in your arsenal. Now, there's a reason why his cornea looked the way it did, is because he had Fuchs. And one of the things that you have to know in patients who go in for cataract surgery, especially if it's a dense PSC like this guy had, is that there's a lot more phaco, there's a lot more energy in there, it induces a lot more vibration, inflammation. So as a clinician, one of the things that's important for you to do is to really bring these patients in sooner, not wait longer, especially when they have Fuchs. It took this, so I don't generally like to refer patients out to ophthalmology, because I just don't feel that unless I want somebody to do surgery, I'm not going to send them out. But when I feel patients start losing confidence in me, it's like, oh, I've got all these friends and they saw better at a week and it's been, 2 months, it's been 3 months and I still can't see, then those are usually when I'll bring somebody else in just to validate that I'm doing. Because, keeping them on a steroid, keeping them on an anti-inflammatory, keeping them maybe possibly on some sort of a hypotensive medication, worrying about the pressure a little bit. So 6 months go by and his vision finally kind of comes down to 20/30. Okay, you can see how clear it looks on there. Well-centered lens. He's got the guttata still. He's got some pigment. The pressure is fine. So I'm like, yeah, I'm out of the woods. No, I'm not out of the woods. 13 months later, he calls me back. He says, sorry to bother you on a Sunday. I can tell you exactly where I was. I was getting my hairs cut. I was at the barber. Okay, as you might notice, I don't really need to worry about that as much as I used to. And he says, my eye hurts a little bit. He goes, I just saw the corneal surgeon and he said, I'm doing great. My vision's 20/30. He said, but it just doesn't feel right. And my vision's getting blurred. So I said, come on, head into the office. So before you guys jump in, let's go to part 2. Okay. This is part 3. We skipped part 2 because I just wanted to say, just when you think You get it out of it, they pull you back in. So here we are, 3 months later. Okay. Does anybody need like that Netflix recap? Does anybody need to like the recap when you're binging and it's like recap, skip, skip, skip? Okay. So we know about our patient that I just mentioned, right? He's got pain, blah, blah, blah. Here he is. So I go in on a Sunday and here's my man. My man's vision is 20/50 in his right eye because we never did cataract surgery on his right eye, and he is a solid hand motion on his left eye. Thanks. Appreciate you. Love you so much. His pressure is 14 in the right eye and 31 with the ORA on his left eye. Looking at the slit lamp, his anterior chamber is deep and quiet. His still has the iris, he's got the PSC. But I think all of you that are looking, if you're, paying attention, you can see that there's a little bit of the, what was it? Steve McQueen and Dustin Hoffman going on in his left eye. Papillon. Was that the movie Papillon? I think it was Papillon. Yeah, look it up, people. Google it while you're doing it. He's got hypopyon. And I'm like, this is one of those cases. And this is like when you're in call, you walk in, you're like, no, what the hell? 3+ injection, the eye's red and chemotic. He's got flare, and he's got about a 1/8 hypopyon going on there. I go in and I take him in. I do an OCT because I'm trying to figure out why he's hand motion, and he's got massive cystoid macular edema. Joe, I think I could even look at that without even really knowing OCT and tell you, yeah, there's a lot of swelling going on that macula there. So
I would concur.
thank you. Thank you. So now what do we do, people? Okay. 6 months later, guy's got hypopyon, he's post-op cataract. And so, I had a patient a long, long time ago. And, without getting too deep in the woods, I had to go in and I had to tap him. And if you don't know what tapping is, it means you basically kind of press on the eye to release some of the pressure as it comes out of the incision, right? In the paracentesis. And while I was doing that, his dad asked him if he wanted water. And the patient looked at his dad, and my Sinskey hook went into his anterior chamber. So I'm like, I want some water, Dad. Can you get some water? And his dad left. I'm sitting there. I said, close your eyes. And I closed my eyes too, because the hook is now in his anterior chamber. Not only is it in his anterior chamber, it's on his iris. So I'm toggling this thing, trying to get it out. The iris is now prolapsed. The iris is through the wound. And I'm like sweating. Okay, I didn't even tell you the part that the dad carries a gun and a Bowie knife, and my son's going into the army. And I'm like, because he had an ICL, right? And his pressure was severely, it was like in the 60s from his ICL. So cut to the chase here. I get the iris. I take some saline and I basically inject it into his anterior chamber to kind of relax the iris, push it back. And now he has about, I don't know, from 2 o'clock to like 5 o'clock iris atrophy. It's just white. It's like, and I'm like, really? Really? Now, some of you out there hopefully are saying, but what was his pressure? So the two things that are important here, his pressure was 9. Thank you very much. And the second question is, but did he die? The answer is no. So dad's already back in the room. He goes, how we doing? I'm like, oh, we're doing great. So I call my surgeon and I tell him, I go, look, hey, good news, bad news. Remember that guy with the gun and his kid? And he goes, yeah. He goes, and I told him what happened. He goes, well, I know who will be seeing him tomorrow. So I go in the room the one day. Okay, kid's there. Technician works him up. I walk in, I'm holding his chart, and I look at him and I go, hey, how's it going? He goes, well, I mean, my eye looks a little funny. And before I can say anything, he goes, my shield fell off last night. Do you think that's what did it? What do you think I said, Greg?
Exactly. That's exactly
I
what
think
did it.
Joe probably would have said, nope, that's not it. I went, hell yeah. I go, I probably did. But you know what? Don't worry about it. It's just a little change in color. Oh my God. So to me, whenever a patient says, do you think I did this? My answer is, yep. So this guy's like, what did I do? I go, I don't know. I don't know what you did. We look at his medical history, no ulceration. He's had no viral infections, no autoimmune or inflammatory conditions. Because we start thinking about hypopyon, you start thinking about what are some of the factors that would induce that. So the one thing he said to me, which really resonated, is he's like, I felt like my eye has just never been right since surgery. Now, I hear that a lot from patients, and that's okay. I'm used to that. But I sent him out for blood tests, and I don't usually send patients out for blood tests. They're expensive,
Mm.
and it's like, oh, let's get some HLA typing, and see if you have maybe Marfans, or does anybody else think, do you think that Byron Trump has Marfans? I mean, he is so tall. I'm just saying. I'm looking at that kid. He's like 7 feet tall. He's got to. So
I think it's Barron Trump, not Byron.
Barron, thank you. Yes.
But
Do
going
you
but
think
going
so?
back to your hook in the iris thing,
Yeah.
in our med surg practice, we get the occasional, not infrequent, pressure spike, 50, 55 after 1 day post-op cataract surgery. And I actually have never had that happen to me when I use Diamox.
Yes, that is true. You're 100% right. 0% of the time do you have anything stuck in the anterior chamber when you
When you use
don't
Diamox.
when you don't put it in there. Yeah. Did you ever use Osmoclin? So I learned my lesson from Osmoclin too a long time ago when the patient looked at me and goes, I don't feel good. And I'm like, no more Osmoclin for me. I'm done with that.
Actually, during my residency, we had some sort of issue, angle closure. I was a resident, so I went to grab the Osmiglen because I read the book, I know how to do it, and I grabbed it off the shelf and I shook it, and it rattled like a Morocco. I said, that's not going to work.
Nope. So you got lucky.
It
Mark,
was it was expired by about 15 years and hard.
Yeah, because nobody uses it.
I was laughing during your talk because I mean I burp paracentesis, not a lot, but when they're up and they have a pressure or whatever during the night and their eye hurts and their cornea is all steamy, and I had one time that I burped and was just trying to do it out of out of just a friendship, doing it for a friend, and the guy was on had iris floppy iris syndrome from Hytrin or something, and as soon as I burped it got caught right. The iris just went boop, right into the paracentesis. I had to call the surgeon up to kind of get it out of the paracentesis. So I was not laughing at you. I was laughing with you. So
No good deed
Never,
goes unpunished, my friends.
never happened with Diamox.
Yeah.
it's hard to get that Diamox through the paracentesis, Joe. It's such a big pill that it's
Yeah, it
hard to
really
get
is.
it. I mean, I don't know how you do it, but
It's also, when you just want to get out of the clinic, sitting there waiting for the Diamox to work, you haven't got time for that. So
Oh no, I just give it to him, send him home, see him next day.
there you go. Love that.
there is a nice instant relief though. The patients come in, they have a high pressure. Yeah, as soon as you burp them, you can do. I'm just giving people both sides. Give Diamox, but when you release that pressure, they do go, oh, that
Ugh,
feels so
it's
much better.
honestly, it's like running around New York City trying to find a bathroom after two Starbucks, 20-ounce Starbucks. Every one of you knows that feeling when you finally find a bathroom where you just give up and just really, it's like, so anyways, so if you see, here's my lab work done. One of the things that was interesting to me is that my friend here had the herp, but he also had a little bit of some HLA typing, B27, he was a little bit positive for. Everything else here, I was hoping maybe he had syphilis. I was, kind of thinking, the great masquerader, but nothing in the blood test really jumped out at me and said, oh, this is the reason why he has, the hypopion, as you can see here. So something else to look for. And maybe something that's just, again, it's like put this in your, put a little pin in it, when you're looking at postoperative cataract patients, if they have persistent iritis, if they have an increase in pressure, and more importantly, if they have oftentimes edema. There was a retrospective study that was done about 10 years ago, and the one thing they concluded is that when you have a delay in cataract diagnosis, it means that the surgeon works a lot harder and there's a greater chance that there is retained lens material that ends up in the patient's eye. Now, I told you, I'm fortunate from the perspective of, why do I have experience? Because I've been doing it so many times. I've seen so many. So this is always in the back of my mind. I'm always looking for it. And so even in this particular case, I'm going to be honest with you, I was looking for it. These are not great photos, But this right here is a piece of retained cortex. You can see some right over here too. You can see the little frill right there in the iris. Okay, this is a little bit of some of the capsule, the cortex that was kind of like lingering right here behind the iris. These are not the patient though, but you can kind of just get a sense of it. It's usually kind of inferior, kind of like where your hypopyon is, but sometimes they can be somewhere else. And in this particular instance, I looked and I thought to myself, something's not right here. The CME drew me, but the bigger thing is that this shouldn't be happening, hypopyon and all this. So you may or may not remember Dr. Janesh, my retinal specialist, who I saw once. I called him up and I'm like, hey, he goes, when are you coming back in to get more laser? And I'm just like, yo, come on, Dinesh, back connection. So I send him in. He sees Dinesh, and he's got a posterior uveitis. The B scan showed multiple refractal particles in the vitreous, and he concluded it was retained lens nucleus. So he does a PPV on him the next day. He took out the lens material, cultured it, started him on some steroids, as well as some non-steroidal anti-inflammatories. And when we think about the most common causes of the hypopyon, it does go back to everything we just said there. But the truth of the matter is that, people have had ulcers, endophthalmitis, keratitis, even just iatrogenic trauma can cause hypopyon. But a postoperative cataract patient like that, somebody who's, tremendous amount of swelling, you think it's maybe just the gutata, but there's other issues going on. Just be real, kind of diligent about looking in the anterior chamber. His was behind the anterior chamber, but it actually, I think it was left in the capsule. I think what happened is that, he opened the capsule when they did the surgery. He had some lingering in there, and it just kind of matriculated into the to the vitreous. Disappointing for him. So, typical treatment for hypopyon, refer to rheumatologist. If you suspect there's an HLA diagnosis, we talked about that, him and I. Yeah, he didn't really seem too impressed. I'm like, okay, steroids, non-steroidal anti-inflammatory treatments, definitely where you want to go. But it also kind of depends on how significant it is. You may want to do a systemic steroid or even an intraocular steroid injection. So to conclude, my patient here, after 6 weeks, his vision returned to 20/30 again. And he literally said to me, because he thought he was really funny, he said, what the fuchs? And I just love that for him. I've seen the guy, but these are those patients you see for life, even though, you kind of lost a little faith in you. He didn't know what was going on. But then after we started managing it, he was doing great. Okay. So here's our second polling question. We have 49 more minutes to get through 3 more polling questions. All right, people. Rhea and Ursa are moons that rotate around what planet? Saturn, Jupiter, Mars, Pluto?
Okay, polling question is open.
Yeah.
People are rolling in. Joe, are there any questions?
There are none. We're good.
Thank you, people, for not asking questions. Appreciate that.
So, Mark, whenever you were, as you had your horseshoe tear there, and I said nice location, so just so the audience knows why I made that comment, was that horseshoe tear was right by the long ciliary nerve, which is the nerve that gives feeling to the eye. So every time that location could have just been about maybe a half a millimeter more inferior, and you would have had really feeling it well. But no wonder you were feeling that every time you lasered. So
That's true. Thanks.
ouch.
If I would have done something sooner, then maybe I too, right?
Right.
I'm a terrible patient. So how'd they do, Greg?
All right. They're rolling in nice. To save some time, I'll just display it real quick here. And they did great. They were mainly paying attention because 77% got Jupiter, Saturn was 19%, and Mars was 5%.
I love you, the Mars people. Yeah, you're the best. Because nowhere did I say Mars ever, but you're just rando. You got to go for it, So very good. Yeah, it makes no sense to me why they have the clinical study of Saturn, but they chose to name the other ones moons that go around Jupiter.
Yeah. So one was a little confused, maybe.
All right, people, it's baseball season. Yep. It's the worst time of the year for me. Why? because I have to deal with spring training. Our practice does the physicals for 6 baseball teams. And between the end of February to the end of, or the beginning of February to the end of, or first week of March, we are doing screenings on these people. And then they come into the practice and then they want contacts and other shenanigans. And I'm going to be honest with every single one of you. Don't meet your heroes. So I'm going to say to you, okay?
Hey, Mark, let me ask you a question. Is that your practice? Like when I watch the Diamondbacks, is that your practice that advertises, that flashes it?
100%.
Is that you? All right, that's cool.
Schwartz Laser Eye Center. In fact, back in the day, early days, Schwartz would get people calling up from New York. Hey, Schwartz, F off. I hope it's he loved that stuff. So yeah, we've been affiliated with these sports teams since the minute Jay started practicing. So, on one hand, it's kind of nice, you see the owner of the Suns come in, you see but yeah, needless to say. So baseball is life, but it can hurt. This is a 20-year-old collegiate baseball player. He's hit in the eye when the ball was deflected off his bat. How many people are watching The Pit? Are you watching The Pit, Joe, Greg? Oh,
Have not done
I
it
am
yet.
not.
let me tell your audience, okay? There is at least 3 patients in this 2-series show that have come in with eye issues, and 2 of them were elevated intraocular pressures. One of them was a collegiate baseball player who's like the dad is like hovering over them. So it's kind of fun to sit there and watch, just go, yeah, I probably would do that, but when you're in an ER situation, I bet you it's just a lot different. So he got hit in the eye. He bled from his nose a little bit. His right eye swelled up shut from edema. And then he had a little hemorrhage that was controlled. So, of course, he's like, I got to go in, get my eyes checked. And this is what it looks like. So some of you at home may notice that, the ecchymosis, you can see some kinds of type of hemorrhaging, but hopefully you also can see that we went from a hypopion to a hyphema. So now we're going, from having that inflammatory, buildup inside the anterior chamber to now having a hemorrhage. And, coincidentally, I am dealing with a patient right now who had an R&R, which is a removal and replacement of their intraocular lens. It was a little hard because the lens kind of was tough to get out, and when it came out, it tore the iris a little bit and broke some blood vessels. So instead, it wasn't a full hyphema, but it was a circulating red blood cells. And they're circulating red blood cells because they look red. Believe it or not, there's a red hue to them. But the bigger thing is that blood in the anterior chamber is like oil and vinegar. It's terrible. It's horrible for the vision. It can really dramatically decrease the vision. So, the bigger thing too, though, is with the iron in there, there's things you have to worry about. So the term microhyphema is used when the red blood cells are in the anterior chamber, but they haven't settled. And that's the patient I just described for you. A hyphema is obviously when it starts to settle. And the most common result of that is blunt trauma to the globe. Soccer moms, baseball players, kids playing around with their kids, it's going to happen. And that force kind of causes the blood vessels of the iris and ciliary body to basically reverberate and break. It's kind of the reason why we take patients and we dilate their eyes to kind of constrict those vessels. When they kind of use a miotic, they're taut. So you have this kind of tug and pull when you have that trauma. So here's another good example of somebody who's got a hyphema. And the way I grade these is exactly like I do with the hypopion. I would look at this and I'd say it's like a 30%. It's like 1/3 of the anterior chamber, maybe 25%. And you want to do that because you want to see if it's getting better. You need to kind of evaluate how you're doing. So these patients need to be checked check their periorbital area, look for their globe for any injuries. It's the standard type of treatments you need to do. You need to run almost basically a comprehensive exam of these patients. Check their vision, check the antechamber depth. If you've never done a Seidel test, a Seidel, for all intent and purposes, is literally taking your fluorescein strip and putting it on the eye. If you have an incision, if you have what looks like a breach or maybe even a laceration to the conjunctiva, is that in not a blue light, Okay, you want to use your normal white light. Put your fluorescein on there. And if it starts to dilute, if you start noticing that the fluorescein is starting to get very, kind of like diluted, less yellow, almost whitish, then that is a positive Seidel. That means that aqueous is basically, kind of breaching through whatever barrier it is there. A negative Seidel is when you put it on there and the fluorescein just kind of looks, kind of like it's just hovering above there and nothing's happened to it. You
Hey,
absolutely want
Mark,
to, yeah.
let me make a comment to the audience because you hit it 100%. But I've watched students over the years like try and find Seidels, and what they do is they'll put a drop of fluoresce in the eye, put the patient, they're standing up, put the drop of fluoresce in, put the patient behind the microscope and sit down, and they think they're looking for a Seidels. And if I want to just echo what Mark is saying and what he's doing, he's literally taking the fluorescein strip and painting it over where he thinks the leak is. You have to do it behind the microscope because if it's leaking, it's going to flush away. So by the time you put a drop in, put the patient behind the microscope, you're going to miss it. And I'm watching what Mark's doing. He's painting with his hand. So if you're looking for a Seidels, you got to have the fluorescein in your hand going over that area you think is compromised, and then you'll see it being pushed away. If you try to do it outside the microscope, you're going to miss it.
100%. Yeah,
Thank you.
I mean, yeah, it's interesting too, is that we talk about like staining patients and stuff, and it's like, you guys have done clinical trials, and it's like when you do, staining, it's like you need to wait, especially with fluorescein for a minimum of 1 to 2 minutes. And I think especially if you're in practice and you're doing these things really fast, you're going to miss a lot of the testing. Here with this, it's the exact opposite. I mean, because the minute they blink, they flush it away. So you really want to do it right when they're Greg, you're 100% right. So other things, obviously check their pressure, any broken bones, you're going to look for, EOMs. You want to make sure that the lens hasn't been dislocated or there's any iris or tear. Oftentimes, these patients might need a CT of the orbit or face, a B scan, or even a retinal consult if their vision is significantly reduced or if they have any orbital type of injuries. Any open globe to me is get out. Vominos, get out of there. I would put a shield on them and send them out. If I knew they had an open globe, I probably would have sent them out before they came in. This is, their typical 8-ball hyphema. Not 100% sure where we got the term 8-ball from. But yeah, this would be, I mean, I don't know about you two, but I don't get scared with a lot of patients. I mean, I always feel like, and maybe again, it's my own hubris. I think I can manage anything, but this one might be one where I'd be like,
Hmm.
might want to get somebody else involved. That's a lot of blood. And the biggest concern, as I mentioned before, is that when that blood lingers in there a lot, it can stain the endothelium. So what are the things that you're watching for in these? Well, you kind of want to see these patients back. And I say this lightly because I hate patients. I don't like going in. And if I could see, I know, Joe, I don't. It's like if I could say to a patient, look, I'll see you back in, every day. No, I will get sick of each other. My favorite thing right now is when patients say, "How are you?" And I'm just like, you know what? I don't have diarrhea. So that's how I am today. Leave it at that. But these are patients you definitely want to manage a little closer. Keep them a little, tighter, closer to the belt there. I would start them on an anti-inflammatory drop minimum, every 2 hours. I mentioned before about, wanting to dilate this iris so we can control some of the bleeding. If you can get home atropine, you be you boo. It's easier said than done. So even if not, just put them on some cycle gel. Anything you can do to try to, kind of control the spasming, and more importantly, try to control, close down that blood-brain barrier that we were trying to get with those blood vessels. But the bigger thing also is controlling the pressure. A large hyphema, you have a much greater risk, like that last patient. That there's not a lot of outflow going on in there, or if not, it's kind of clogged up. So there's a greater risk of pressure there. I would use something like a bromonidine, maybe even a beta blocker. You want to avoid the carbonic anhydrase inhibitors, especially if you think somebody has sickle cell. And there's some school of thought, and I'm going to ask you, Joe, to pipe in here, is that a lot of people look at prostaglandins as having a inflammatory uh, kind of a secondary effect. And I don't
Mhm.
subscribe to that. I would use a prostaglandin even in somebody who's inflamed because I think it works so well. What's your thoughts on that?
I agree with you. I mean, the whole idea is overblown, overstated, overrated. I mean, it will work in uveitic glaucoma. It just doesn't work as well because of the prostaglandins that are already there. I mean, you're certainly not going to hurt a patient. If you have a sample of it, what the heck?
Right. I mean, Diamox, Osmoglen, I'm going in hardcore. I mean, truthfully, you probably would want to drain some of that blood out of there, but I'm not ballsy enough to do that. I could see Greg doing that, but I'm not going to do that. Sorry. No can do, my friend. But what about somebody with cystoid macular edema? Or what about somebody with a high, maybe a lot of cells and flare? Would you put them on who has a high pressure? Would you also not worry about like a prostaglandin?
I probably wouldn't put it on as a first line, to be honest with you. I wouldn't hesitate to do it if I had to.
Mhm.
I can tell you in my entire career using many thousands of prostaglandins, I can only think of a single situation where I truly felt I gave a patient cystoid macular edema. And it was somebody who I had imaging beforehand, and then sometime later, there it was, and the patient had had cataract surgery and open capsule years earlier. So one person, just ironically enough, is when I was at Nova University. It was the vice president of the university that I did it to.
Wow. Too bad it wasn't Sheckman. That would have been okay.
No.
So, anywho, very cool. Where are we at here on this patient? Oh, yeah. So remember I keep talking about the staining that can happen on the endothelium. This is not a great picture. I just, could not get a great picture, but there's significant amount of staining of it's basically the iron basically causes, it's almost like rust on the endothelium, and that is not good. That is not good for the patient. It can disrupt the endothelial tissue. It can change the quality of the vision. So these are the things that we really want to try to avoid. So when would you consider referral? Well, right off the bat, you can't get the pressure down. You start seeing the blood staining developing, or if they keep bleeding without clotting, any sickle cell patient, or better yet, somebody that has a spontaneous hyphema, somebody just walks in without trauma, okay? Because trauma is not spontaneous. And they come in and they're like, yeah, living my best life and my vision's really blurry. And then you start seeing some blood vessels coursing in there. You start seeing some leaking. It could be, iris neovascularization. It could be something else that's causing this. So surgical treatment would be an anterior chamber washout, which is obviously the most common. That paracentesis that we mentioned, that's the incision that we like to burp. It's just kind of going in, opening up the anterior chamber, letting some of that aqueous out. You can squeeze a little Diamox in there if you get a chance. They do trabeculotomies with an anterior chamber washout, and then sometimes they may need a PI if the pupillary block starts to develop in these patients.
Hey, Mark, a question just came through. Well, two questions about getting home atropine. I said no, I can't get it. But another question was, does acetazolamide affect the endothelium? Thus, must be avoided in hyphema or other edema.
Say that again. What was the
Does
question?
acetazolamide affect the endothelium and thus must be avoided in cases of hyphema or other edema?
I don't think so. Do you think so, Joe?
No.
I don't think so.
No.
Yeah, I know. Good question, though. Thanks for the
Mhm.
question. And yeah, home atropine. What a pain in the ass that is. Thanks for
I think
bringing
they're
that up.
going. I think they're going with the old. Remember, like if the Fuchs dystrophy, you don't want to give a carbonic anhydrase inhibitor because it can make it worse. So they're going with acetazolamide. I wouldn't be
Mhm.
concerned about there in this case at all. I think that's what they're going with. Like, which glaucoma
Yeah.
drop would you not give to a Fuchs patient? Would be COSOPT or AZOP because
Yeah.
it inhibits the endothelial cells. In this case, for the person that's asking, I think that's where they're going, and I wouldn't
Yeah.
have any problem with that. So
Yeah, especially when it's just like short term like that too. So what do we tell our patients? Well, obviously the soccer mom, you got to tell your kids they got to, chill for a little while, keep their head elevated. You want them to maybe avoid aspirin if they can, or ibuprofen type products, anything that's like a blood thinner if they possibly can, if it's life threatening for some patients, that I just tell them your life's more important than these things. You also worry about that glaucoma risk. I mean, again, angle recession, you want to bring these patients back. You know, I don't know about you two, but I always kind of laugh a little bit from the perspective that how many times do we, tell somebody they have primary open angle glaucoma, and like how often do we actually look at the angle to determine that it's open? Now, Joe, you may say 100% of the time, every time. Greg, you might say 90% of the time. But I think, let's be honest, people, right? Nobody's reaching for four mirrors. Nobody's reaching for their gonial lens that often. But in a case like this patient, I think it's important. Yeah, I think now, the funny thing is we can sit here and say, oh, do gonio, but do you know what you're looking for? And so for me, anytime, I've had a hyphema patient, I've gone back to look and kind of research what it is that I'm looking for. And I've never seen, have you ever seen angle recession? Has either of you two ever seen a patient with angle recession? Greg, you have?
Oh yeah,
I've, s-
I've seen quite a bit of it. I've seen some very, very serious ones. I've seen some minor ones. For 18 years I did nothing but glaucoma academically, so it's not unusual. But I will tell you right now, this, you can quote me on this, 40% of all angle recessions are diagnosed by imagination only. When
Really?
somebody is struggling to explain an asymmetric or unilateral case, and I've seen it so many times, they'll put a gonial lens on, and then in the chart it'll say questionable angle recession, and then the next visit they'll say questionable angle recession. Third visit it becomes angle recession. Done.
Interesting. Very interesting. Yeah. Good times, people. Post-surgical hyphema is pretty often, as I mentioned, I just told you about my post-surgical hyphema that I have right now. Peripheral iridotomies, cataract surgery, our minimally invasive glaucoma surgeries, or patients that have, diffuse heterochromatic iridocyclitis or UG syndromes, other ones. Patients that have had a history of an anterior chamber IOL, or even just a poorly positioned posterior IOL, can cause a hyphema. So these are all things to kind of look for. But again, a tell in some of these patients, honestly, is just a rapid change in their vision. And you look and it looks like they just have a really severe iritis where it's just a lot of cells. Just check those cells. They're smaller. They don't have that white. They have a little kind of almost like a pinkish hue to them. So here's some examples. Oh gosh, why did that go so fast? Here's some examples of some hemorrhaging from patients that have had some MIGs. Not terribly uncommon. These go away relatively quickly, but again, it can kind of disrupt the vision a little bit.
Mark, which MIGS procedure is that?
Gosh, I don't even
Or
know. Thanks for
yeah,
asking.
okay. Yeah,
Yeah,
I
yeah,
don't know if it's hook dual blade or if that was it doesn't look like they put a stent in there.
yeah. No, this
My
one,
surgeon
the
does
lower one's
hook
a
dual
scale.
blade, so I see them. So I
Yeah,
see these quite a bit. So I was just wondering. So.
yeah. Sorry, I can't remember.
All right, no worries, no worries.
Sure. Yeah. Okay. Hey, spontaneous hyphema. We mentioned it a couple seconds ago. Neovascularization of the iris is probably going to be the most common. Less common, we start thinking sickle cell or melanomas, even herpetic uveitis. So those are the ones that are going to be more disconcerting. Those are the ones that I probably would tell you to refer out of your practice, because they're going to be a lot more invasive in the perspective of how you're going to manage these patients. Okay. So we're running up on time here. We got like 30 minutes left, give or take. Two more cases. You guys tell me. If you guys need to take a break, all of you guys out there, then just you stand up and just take your phone with you. You're probably taking a break anyway. So that's the beautiful thing about webinars. We have no idea what they're doing. They know what we're doing, but they're laying in bed with something propped up, or yeah, who knows. Okay, friends, this is called Manscaping 2.0. Okay, this is one of my favorite cases because I told you that I love walking into a room and just, giving people crap. And honestly, I kind of like it when they give it back to me because then, we're the same. So this 77-year-old Hispanic male, his primary doctor told him he had to get his beep in to get an exam. His exact words, so here I am. He smokes. He's like, don't tell me that I can't drink my beers, you know, non-insulin dependent diabetic. Here's his metformin. You know, he's skinny, so he doesn't need to be on, you know, Majora or Ozempic. No known medical allergies. Ocular history is negative. Okay. Here's his visual acuity. Uncorrected is 20/40, 20/20, 20/25. His pressure is 13 millimeters in both eyes. Now, if you look at this lamp, he's got a grade 2 Demodex. You know, I usually like to look at the collarettes, and if it's about 100, you know, maybe 2/3 of the lashes, then I'll call that a grade 2. When I look at my Boehmian gland secretion scores, a 3 to me is basically a patient that has pretty good glands, right? They're working okay. A 2 means that it's kind of more turbid and just kind of maybe more baby spit up. So, you know, he's got some MGD, but it wasn't horrible. Open capsule in both eyes, dilated fundus exam, retina was flat, no, you know, any neovascularization of his optic nerve or anywhere else. But the thing that struck me the most is that the dude, his eyebrows are insane. Okay, gentlemen. So I'm gonna do a little manscaping here. Just look at him, okay? And I'm just like, I said, look, I go, maybe you're past the time where you care about the ladies, my friend, but your brows are hideous. I go, do you ever cut them? And he looked at me and I had like little stubble on my head. He goes, well, he goes, you're one to talk. He goes, is that a chia pet you got going on at the top of your head? And I'm like, I love this man. I love him so much. And as I'm talking to him and I'm looking at him a little bit, I'm like, look at the one eyebrow that is like going straight into his eye. I'm like, dude. And then as I look at him, I'm like, did you have a dog take a bite out of your lower lid? Because your lid looks terrible. Now, I still can't get past the eyebrows, but now I'm looking at his lids and I'm thinking there's something just not right about that lower lid. So when we start thinking about lesions, we start thinking about who to refer, what we need to do with it. 90 to 95% of our eyelid malignancies are going to be basal cells. Simple, easy enough. Yay, basal cells. It's, you know, kind of the when patients come in with a Band-Aid on their face, you know, it's the Arizona tattoo, right? It's the most common malignant tumor of the eyes, arises from hair-bearing skin. It's interesting because they resemble kind of like an inclusion cyst, but it's like syphilis, people. It manifests itself in a lot of different ways. You know, it can fibrose, it can be below the skin, they lose lashes, they get notching, like you just saw there, retraction, chalasia, chronic blepharitis. When I started thinking about whether or not it's somebody that I think I should be concerned with, well, I start looking at the location. I start thinking, are there other things that are associated with it? You know, fair skin, sun exposure, smoking. You know, the one thing that I love about, you know, patients when they say, well, you know, do I have a risk of developing and they're smoking? I'm like, yeah, dude, yeah, you smoke. You have a risk of everything. The number one risk for macular degeneration is, well, it's age, but smoking, you know, it's like you can't get past it. So my smokers are my favorite patients because I can go, well, you smoke, sorry, you know. So nodular, metaform, you know, the biggest concern is that these start to kind of, you know, penetrate deep into the tissue and they start to, for all intent and purposes, metastasize. So we can break down these different, you know, types of cells. You can see the squamous cells, which are a little bit more superficial to the epidermis. The basal cells are a little bit deeper into the dermis, and then the melanoma cells are basically even further down into the dermal tissue. So looking at here, I can tell you with all, you know, certainty that this is an ulcerated lid margin. And that's all I can tell you, because you see the blood vessels, you see the activeness of this, you see the goopy yellow shit coming out of his eye. Oh, I'm sorry. Okay, you know, but you also, if you look at him, do you remember those milia that I mentioned to you back almost an hour and a half ago? He's got tons of little milia, right? And I like go back and I look at these pictures and I'm like, oh, look, he's got what we just talked about, that alpenglow sign. He's also got horrible, horrible eyebrows. And I'm just like, I can't get past those. So the only way you're ever going to know what this is is if you biopsy it. Now, I'm not cavalier about sending patients out for biopsies. If it is something that I hate and I think it's hideous, then yeah, I'm going to send them out. But you biopsy, when you're in doubt, you cut it out. You biopsy it. Now, what do? They'll do incisional biopsies if they suspect a malignant lesion, shaving it or punching it. They'll do an excisional lesion, basically on the outside, if they suspect that it's a benign lesion. They'll check the margins, not as thoroughly as they would if they thought it was an incisional one. So this is what an incisional one looks like. Okay, because it was pretty significant. You saw the hemorrhaging that was there. I know some colleagues of ours that will say things like, if it bleeds, then it's a malignancy, or but I don't necessarily subscribe to that, because we're a very inquisitive, creatures. We're picking and prodding at our eyes. Now, I want you to look at this, because part of what's really important is that if you are going to send somebody out for a biopsy, is you got to think about what you're going to be doing to this patient for the rest of their days. So you want to get a good ocular plastic surgeon, and in his case, he needs to get somebody to take care of those eyebrows. Okay. This is 2 days post-op. And you see, look how, you can see some of the sutures that are going on there, but they grafted some tissue, I think from behind his ear. They fixed it down there 2 days post-op. That is incredible. Look at my man 2 months post-op. What's the first thing that jumps out to you?
His eyebrows.
This rogue curly hair on the side. What he did in 2 months, he's done nothing about his eyebrows. Yeah, just the guy's driving me crazy. But you look at that lid, you could, there's no lashes there, but that was a beautiful job. Just an absolute beautiful job. So we're going to stop real quick in the middle of our case here and do our third polling question. So Greg, you ready?
I am ready.
Which of the following is not a sign when considering retained lens materials? Is it an iritis? Is it the edema? Is it a vitreous wick? Or is it increased interocular pressure?
Joe, any questions?
There are no questions from the audience, but I'm going to throw a question out to you, Mark. In terms of retained lens material, what's the longest you've ever come across, the latest you ever came across something?
That's a great question. We had a patient who came in. It had to be, because you have to remember, the lens material itself is foreign material to the body, because it's encapsulated as an embryonic tissue. And so once it's exposed into the eye, it basically becomes, you have antigens and you have inflammation that basically try to tear it down. We had a patient who, I think it was about 9 years post-op, and he had a YAG laser done. And what happened is that he had wedged in his capsule some of the material. And when we opened up the capsule and it exposed it, it got into the vitreous, and it basically developed a vitritis. And yeah, it was crazy. And that was the only resolution for that. But that's usually the case. It's usually there pretty immediately.
Yeah, I had one that was 13 years after surgery, and he had a YAG and was playing tennis, and his vision got all cloudy, and he had a history of a retinal tear, so he thought it was his retina.
Oh yeah.
And no, he shook a loose piece of capsule right into into his pupil.
Beautiful. Yeah, you saw
13
that
years.
one with the frill where it's coming out, which just exposed it. So, Greg, how'd they do? Does anybody even know what a vitreous wick is?
Well, I think so, because 74% of them went with vitreous wick. So
Nice, very nice. The vitreous wick to me is always the other fun thing to look for. It's like when you see a pupil that's irregular and taut, and it's like you just want to find that vitreous material that's kind of attached to the incision. But yeah, so yeah, good job, people. All right, we're moving on. We're still kind of in our case. So what do we need to be wary of? Well, we need to be wary of the fact that when we start thinking about eyelid neoplasms, that this is keratinizing tissue. Okay, as we talked about before, the lens keratinizes, the cornea keratinizes, everything's keratinizing, and the epidermis tissue is keratinizing as well. So you also want to look for, what the origin of this is. And so for us as optometrists, our goal is to just identify something as not being normal, and then let somebody else make the diagnosis. And the only way they're going to make the diagnosis is biopsy. So most, fortunately for us, our lesions are non-malignant. Clinical judgment, it's not 100%. So you definitely need to kind of get in there. Some things you can look for is that patients have had a history of prior cancer. Those patients that, oh yeah, I've had a squamous cell and a basal cell, I've lived my best life. People that like to be out in the sun. Let's say they go to Disney a lot and they don't put on suntan lotion. Speaking to you, my friend. Me here in Arizona, it's extremely common. You get those people coming in, past radiation, smoking again, as well as our skin type. Smoking is my number one. Love that guy. Some other clinical signs to think about is something that is slow and painless. Okay, patients don't walk in and say, owie, this hurts. They walk in and just say something, yeah, I think I've got a little bump here, or hey, have you noticed that bump? You don't get these big horns of tissue growing on patients overnight. So this has been going for a while, and you just want to ask them, at what point did you say, maybe not today, maybe tomorrow? How much bigger sunglasses are you getting? So you start seeing ulcerations. So to me, an ulcerated lesion that is slow and painless, that has irregular borders, irregular pigment, is when I start getting a little concerned. Loss of lashes, loss of meibomian glands, change to the architecture is really important, as well as you start seeing those bleeding or telangiectasias. Some other things to kind of think about as well, would be anything that has the potential to, go subcutaneous, or lesions near the puncta, things that are close to the lymph nodes, or anything that restricts the intraocular muscles, extraocular muscles is going to be concerned. So let's just run through some photos here. I love looking at pictures. On the left-hand side here, basal cell carcinoma. Okay, you can look right here, you can see it, and you're like, yeah, I mean, it doesn't really look all that aggressive, but it's ulcerated a little bit. It's getting bigger. It's painless. It's worth getting a biopsy. And sure enough, it was a basal cell. Here's another one on the upper lid. Don't forget, the best places to look for lesions are where you wear glasses. Just think about where the frame is, where it goes to the temple, and don't forget to look behind the ear. Okay, so you just grossly want to look at these patients. Here's somebody that was dead. She came into the office and she was dead, right? You can see that she's just, and then look, you see the lesion that was down there is removed. And now look at her. She's back to life. Okay. She's back to life. Kind of like the way I am right now with my orange face. Okay. So there is exactly before, here it is after, and there it is after again. Going in, get a good surgeon who knows what he's doing. This is a really aggressive basal cell. I probably would have thought this was something a little bit more, but it's not. Here it is after the treatment. Here's another basal cell. We can go on and on. But there are other carcinomas. So real quickly, squamous cell carcinoma, 40 times less common than basal cell, most common epithelial malignancy of the conjunctiva. Remember, I told you basal cells are only on hair-bearing tissue. So if you see something on, let's say, the conjunctiva, then it's not a basal cell. You're looking at something that's potentiated by immunodeficiency. It can resemble inflammatory lesions, and these can and do metastasize quite easily. Here's some examples of some squamous cell. This is a really aggressive form, right? Here is one that is keeps me up at night. This was a patient of mine, got to be 25 years ago, maybe 20 years ago. I thought it was just a pterygium gone bad. Sent it out. A colleague sent it out, comes back squamous cell. So even like a lesion like this, how do you know it's a squamous cell? Because you biopsied it. More squamous cells across the board there. How do you treat them? Aggressive surgical excision, and recurrences can require some orbital removal there. The sebaceous adenocarcinoma is a little more challenging. It's a little more tricky. It's rare, maybe not in China, and I still don't know if you are a Chinese native and moved to America. Do you still retain that 33% chance? Don't know. But these are very malignant. They can be lethal. The sebaceous gland origin is obviously the usual kind of culprit, the meibomian gland, the Zeiss, the Krunkel. The thing about this is that even though it's females greater than males and upper lids, they look very much like a chalazion. You know, they kind of start off hordeolum-ish, look like a chalazion, and oftentimes I think, you know, they don't look super aggressive. Okay, you know, obviously these are pictures of that are a little hard to tell, but you know, the truth is that the most common patient is usually after 50 years old. They have yellowish in color, but we as optometrists often misdiagnose these sebaceous adenocarcinomas by an average of 3 years. Because you're looking at these patients, you're managing them, and you just think, I don't know, that looks like SLK or that looks like Panis. And so if you have a recurrent hordeolum or recurrent chalazion that just doesn't go away, that's always in the same place, looks a little red, maybe even a yellowish, angry looking, send these patients out, man. You know, so beware of that chalazion that later causes loss of lashes, destruction of the meibomian glands, and so forth. Lastly, there's malignant melanomas, 5% of all skin cancers, less than 1% of eyelid malignancies. These can be de novo, they can be from a nevi or lentigo maligna. Now, remember, we don't really acquire pigment until we're teenagers. So, you know, you don't get a lot of these pigmented lesions, especially on kids. So they may have them, but you're just not seeing the pigment. So usually you're going to see these, you know, usually in your second or third decade. And they can be variable. Irregular borders, they can ulcerate, they bleed. And there's just a lot of different forms that we just mentioned. So, you know, here's a couple good examples. You know, when you look at somebody who maybe has a little bit of like hyperpigmentation or melanosis, the melanosis tends to be more uniform. It tends to be more flat. When you start looking at a melanoma, it tends to be more elevated, clumpy. It almost kind of looks like it's just kind of 3D, as you can kind of see in both of these pictures here. How do we treat these? You know, it affects on the prognosis. Preoperative metastatic workup, regional lymph node dissection is often important because the malignant melanomas can be very, very aggressive. And I know that some of you guys probably are just had your dessert, or you're thinking about dinner, or you want to bring a friend over to come see this, but this is a patient that had a very, very aggressive form of melanoma. And you can see that they took a large amount of the tissue to get the edges. They grafted the tissue on there, obviously from the neck, pull it up, fix it. But I want to show you how well this looks afterwards. I mean, that is just really, really nice. Really nice work done. So she's super happy. She looks like she has a Bell's palsy now, but you know what? I'd take that. If I were you guys, I'd take that, you know? And I was thinking she should hook up with the other guy. What do you think? Should we make a match made in heaven with our manscaping dude? No? You guys are sleeping over there? Okay. So here's a couple more examples of some melanomas before and after. It's our second to last polling question. And to be quite honest with you, I think I have one more case after this. So I think we're rolling. Here's our polling question, people. If you're still with me, which of the following is not a spontaneous hyphema? PDR? Is it herpetic? Is it hemophilia, or is it trauma? Greg, if we don't get 100% on this, it's going to be pretty disappointing for the crew.
We are good on questions, by the way.
I think our East. So do you guys? No, I guess it doesn't change. I don't know why I just thought that, because next Sunday is daylight savings. It's when y'all get to turn your clocks back.
You stay the same, right? You go 3 hours from us, right? Is that what happened?
Exactly. Yeah. Yeah.
No,
You
we actually have to
jump
set the
ahead.
clocks forward.
Forward, yeah. So you jump ahead. So right now in Arizona, we are an hour ahead of California. So we're mountain time now. We're 2 hours from the East Coast, 1 hour from Central, and then when everybody goes, then we're back to Pacific. And so so this is the worst time of the year for me, because when you start saying, "Oh, hey, let's set up a time where we can talk," or "When can I see?" Right? You have to like think Pacific, Mountain, Pacific. It's terrible.
Yep.
How do we do?
We are doing okay. We have, I'll
What?
just
No. Okay.
yeah, you're not gonna be happy. So 16 went with proliferative diabetic retinopathy, 46 went herpetic, hemophilia is 7, and trauma is 30. So your two winners are B and D.
Okay, so people, okay, not spontaneous. Okay. Herpetic is spontaneous. Hemophilia is spontaneous. Trauma, that is not spontaneous. That's like, yes, I did hit myself. That hurt a little bit. Sorry about that. All right. Our last case. Hotel, motel, holiday. I don't know. For some reason, whatever I name these, I have no idea why I did that. But yeah, so this is a case that kind of comes out of the fact that we are so digital that every single patient, any single friend, any family member, do you guys get people to just say, hey, Greg, do you have a second? My sister's cousin's brother's friend has something on their eye, and they send you a picture and they just want you to diagnose it. Joe, do you get that too?
It's happened twice already during this webinar, Mark.
Yeah, 100%. Yeah. It's like, hey, what do you think this is? And I go, I don't know, but whatever it's attached to is ugly. So
Hey, Mark, I just, during this webinar, I just diagnosed multiple effervescent white dot syndrome via messenger.
get out.
Swear to God.
I wouldn't know Mudes if it hit me in the face. I would be, jeez. This is like a Jerry Sherman type episode. Do you remember Jerry Sherman, how he used to always have like, I have a kid came in with contacts. He sneezed and I diagnosed cancer. I sent him out for him. I was like, okay, sure. So here's my motel. Can I have some more, please? All right. Oh, last polling question. Okay. Had to squeeze it in somewhere. Put it in too soon. Sorry, friends. Let's do it. Which
Okay.
carcinoma can masquerade as a chalazion and delay diagnosis for upwards of 3 years? All right. So all of you guys that just was ratchet on that last question, okay? I need you to start mogging a little bit. All right. Let's pull Mog. I know some of you millennials are cringing by me saying that, but come on, okay?
They're doing
Is
they're
it
doing
is
well
it
on this one.
melanoma?
They're
Is
gonna
it
do
they're gonna do it?
okay.
Sebaceous adenocarcinoma? Is it squamous cell or is it basal cell?
All right. So for the sake of time, so you can get through your case, they're rolling in. You're gonna be happy with them. You've got 70. Oh, it just changed from 77, but 74, 72 are going. I'm going to end it so it doesn't go down. Sebaceous adenocarcinoma. Woo.
Yeah. All right. Thank you guys for paying attention or not. Love you guys. So here's the picture that I got. Okay. So patient calls me, says, hey, my eye's really bothering me. She goes, can I send you a picture? And you know, if it's a family friend or if it's somebody, then I always want to kind of flex my, hey, I got this. Okay. But looking at this, so many thoughts. So many thoughts. Okay. It could be anything. Our differential diagnosis on this badass is allergic conjunctivitis. Okay, you guys on the East Coast, maybe not so much you, Joe, bug bite. What is that bug bite? Have you ever seen a bug?
It's never a bug bite.
I don't it's what is it, like a black recluse or something? I don't know. I've
The
never seen a
spider,
bug.
the dreaded spider bite.
Yeah, it's insane. So when you look at this eye, it really kind of goes to the heart also is that you really can't differentiate a bacterial conjunctivitis, a viral conjunctivitis from an abrasion or an erosion that's happening on there. I oftentimes will tell patients I think it's hot tub because hot tub is human stew. It's disgusting. You know what? I don't care. Anything can happen. So it's really hard to differentiate this. So one of the things that I always do, and this was kind of bore out of working in a surgery center and more importantly, working with people that, will tell you they're using their drops or tell you they're doing something, but you never know what it is. We always have our patients bring in their medications. And, if I can digress for another 30 seconds, I was on call. This is about 20, I can tell you exactly when this was. It'll be 29 years in March. That's how I know this. Why? Because my son is 29 years old and his mother was pregnant with him when this phone call came in. So 29 years ago, I had this patient call up and say that it's, they can't open their eyes. They're post LASIK. And I said, okay. She says, no, I like physically can't open them. And I go, well, it's 3 a.m. They should probably be closed. But what time is your appointment? She said her appointment's at 8. I said, okay, I'll get there early. I'll see you at 7:59. And, there's some patients you remember just, forever. So she comes in, her husband's in scrubs with a stethoscope. Now, this is before we all started wearing scrubs, so he just wanted me to know that he's a physician. He's staring at me, spitting daggers at me. Walk her in, bring her in, sit her down. Now, for my friends who are watching The Pit, this may be very familiar to you because I sit her down behind the slit lamp and I'm looking, and sure enough, her lids are freaking completely sealed shut. And I said to her, I go, what did you put in there? She goes, just whatever the drops I was supposed to. I brought them all. Pour out the bag. In the bag is, Refresh. I mean, at the time it was Acular, but it was LS, less sting, Gadifloxacin or Vigamox, and then of, and I picked,
Oh, we lost you for a second there, Mark.
no?
Oh, yeah, you're back.
Okay. I pick up,
Step back 10 seconds.
okay, so I pick up the bag, if you didn't hear that, okay, and I pull up the bag and I look inside the bag and there is Vigamox, Gadifloxacin, there's Acular LS, and there's also Crazy Glue. And I hold up the Crazy Glue and I look at the husband and he looks at me, he shakes his head, he stands up and walks out of the room. Now, if anybody's been married, you know exactly what that look was. I did not have to go through this night like this. And I said to her, I go, you have a bottle of Crazy Glue in here. And she said, oh, she goes, I use that for my blister. I mean, for my warts. I put them on at nighttime on my warts. And I said, okay, disgusting. And then she said, do you think I got that in my eye? And I go, yeah, I think you did. So I didn't have to, but I chose to cut off all her lashes, opened up her eye 2015, 2020 after her LASIK, living her best life. This to me was always one of those things where it's like, my first question for these patients is, what did you put in your eye? So looking at her eye, here it is in full bloom. I asked her, what did you put in? She goes, well, I used some drops. And this is the drop she put in. And I said, okay, awesome sauce. I go, so you put in grapefruit seed extract, which obviously, is a very acidic and no bueno for the eye. So whenever I hear people say, oh, I did something or I added something drops, I cringe a little bit, but just a reminder that, alkali burns, these involve pH, chemicals a little bit higher. They're way more dangerous. These are lye. These are things that, just they can go straight into the eye. More importantly, they can cause cataracts and glaucoma. I had a patient who was cleaning. She was a month post-op after her Symphony IOL. She was seeing fantastic and she got lye in her eye. 4+ corneal edema, stria. She had everything terrible going on with her. It looks like she even had, an abrasion and erosion. The acid burns, with the lower pHs tend to be a little less serious. They're still and can penetrate the eye over, maybe a longer period of time, but they're less disconcerting to changing the quality of your patient's vision. And then there's irritants. Don't forget, if you have patients that come in and they just have this vague kind of just burning irritation, don't forget the environmental questions. Is there construction being done? Are you doing something in your house? Because there are irritants that are neutral pH that can cause significant amount of irritation and burn to the eye. The chemical burn symptoms, they're just like everything else, right? Just like us, redness, irritation, pain, swelling of the eye. I mean, that picture could have been a preseptal cellulitis. That picture could have been an erosion, an abrasion, could have been a foreign body. All of these things kind of feel and look and act the same for patients, and you're really not going to know until you talk to them about what they possibly put in their eye. So some of the steps, especially with triaging and phone, real quickly, you want to talk to the patients, if they're wearing contacts, tell them not to take out their contacts. More importantly, if you can, if they're doing something industrial, if they know what they got in there, to try to irrigate it and flush it while they're in their workplace or at home. And more importantly, if you think that there's a breach to the globe or if there's any significant change to their eye, then dispatch emergency services to where they're at. So treatment, especially for ones that are kind of more milder, especially when we start thinking about these acidic, is prophylactic antibiotic. Start them on maybe a steroid, a cycloplegic for the pain. I am big into using amniotic membranes, especially in all of these patients, because I really think that it helps to kind of help heal the tissue. So in a milder case, I'd probably put a dry one in. One that's more necrotic with my lye patient, I would absolutely go with my cryopreserved. Don't forget about using things like sodium ascorbate drops, especially while they're awake. That'll definitely help with the healing. And then vitamin C is another thing that I talk to a lot of patients about. These take hand holding. They don't heal up overnight, and just be cognizant about any significant changes there. And that concludes my presentation. But I do look really suntan. What is going on here? Yeah, that's my presentation, my friends.
Well, going back to really briefly to your last your last case, yeah, I actually saw the same situation. It was LASIK. It was a bottle of Alrex that was confused, and
Oh.
the patient used a nail glue with a pink cap called Lure on it.
Nice. Nice.
Give me
Yeah.
one
Alright.
second here. Let me give me 1 second, everyone. If you look right here, it says survey. There's right where the green circle is, there's a little red dot. You can start that survey. And then Mark, always a pleasure. We're doing anterior segment case challenges or anterior segment challenges. Joe, any questions?
No, we're all caught up. I want to thank you, Mark, for joining our podcast. I guess we can call it today.
Yeah, it's awesome. Appreciate you guys. You guys are doing good work. Keep educating all of us, and appreciate you. Good night, everybody.
Thanks, Mark.
Peace
Thanks for
out.
being here.
You guys got to stay. I'm logging off.
Okay. So that will conclude anterior segment challenges. This was a synchronous virtual course. Thanks everyone for attending Optometric Education Consultants National Webinar Series.